Hello everyone, welcome to the ENT corridor. This is Dr. Varshita and our topic for today is otomycosis. Starting with the definition, it's an acute fungal infection of the external auditory canal. Next comes a very important Viva question, which is nothing but the causative organism of otomycosis, which is nothing but Aspergillus niger, Aspergillus fumigatus, and Candida. Out of Aspergillus and Candida, Aspergillus is more common. Talking about the pathophysiology, so we have our ear, then we have the external auditory canal. So this external auditory canal has some normal defense mechanisms like an acidic pH, okay, then we have the squamous epithelium, then we have the wax production, and then we have the epithelial migration and normal bacterial flora inside this. Okay, these all protect the external auditory canal. But whenever there is a disruption in the local defense mechanisms, airborne fungal spores get deposited in the external auditory canal, and whenever there is a favorable environment, these spores they germinate and they produce hyphae, which will later on turn into this fungi, and it will produce inflammation, edema, and accumulation of more fungal debris in the external auditory canal. Talking about the predisposing factors, we have humid climate, instrumentation of ear, increased use of topical antibiotics, and steroid preparations. What does this do is it kills the normal bacterial flora of the external auditory canal, and also it alters the pH. Okay, it alters the pH of the external auditory canal. So it is basically disrupting the normal defense mechanism of the external auditory canal, which is also a predisposing factor to the fungal spores. Okay, due to this, there is the development of otomycosis in the external auditory canal. It is also called as secondary otomycosis. Okay, next we have immunocompromised host, then we have people wearing hearing aids with occlusive ear molds. Now what happens is the epithelial migration gets hampered in such cases. When there is a mold over here, the epithelial migration or the ventilation of the external auditory canal does not take place like in a normal person does. So as a result, there is development of fungus or otomycosis in the external auditory canal. Okay, now talking about the clinical features, so what this is very important, because this is the differentiating feature between the bacterial otitis externa and the fungal otitis externa. In fungal otitis externa there is intense itching. Okay, there is intense itching, whereas in bacterial otitis externa there is very severe earache. Okay, so this is the main differentiating feature, or basically a Viva question, that there is a difference. What is the difference between the bacterial otitis externa and the fungal otitis externa? Okay, next, the otoscopic examination, which is very important. Niger has black headed filamentous growth, whereas fumigatus has pale blue or green color, and Candida has white creamy deposits. Now when we are talking about the resemblance, yes, this is another Viva question which is asked. It resembles a wet newspaper appearance, or a cotton wool appearance, or a black pepper, which is especially seen in Aspergillus niger. This we already talked about what is secondary otomycosis, and this is very important that Aspergillus, which is there, it is the main cause of secondary otomycosis. Here I have provided you with a table about the differentiating features between the bacterial otitis externa and the fungal otitis externa, which is a very important Viva question. Okay. Next, we are talking about investigations. Investigations is mostly never done in otitis externa, because it is a clinical diagnosis, whereas these all are Viva questions, like when do you do a lab test, and these Viva questions are mainly for PGs. Okay, so when do you do the lab test, what are the findings on microscopy, and what is the culture, and when do you send for cultures? Okay, so when we are talking about lab test, when do you do the lab test? In case of recurrent cases, in case of immunocompromised cases. Okay, when there is a mixed infection that is suspected. And what is the microscopy? In branching hyphae is seen in case of Aspergillus, and yeast and pseudo hyphae is seen in case of Candida. Okay, and what is the culture media? That is SDA, which is done in case of treatment failure, in case of immunocompromised patients, and in case of recurrent otomycosis, and in case of medico-legal documentations. Okay. Now talking about the treatment, so the main treatment is ear toilet, which is nothing but syringing, suctioning and mopping. Then we use topical solutions only. Systemic is very rare. In topical form we have nystatin, clotrimazole, then we use povidone iodine, salicylic acid, acetic acid, boric acid. And the treatment duration varies from 1 to 2 weeks minimum to a maximum of 4 to 6 weeks. Now why there is need to do the treatment for 4 to 6 weeks is because fungal spores are quite resistant. So in order to kill them, you need to administer the topical medications for 4 to 6 weeks at least. Now what is the sequelae, what is the consequence is, in many research papers you will find these two consequences are more common, that is serous otitis media and tympanic membrane perforation. Now the next question which usually the teachers ask is, why does otomycosis recur? Okay, so first is because of incomplete oral toilet, second is because of persistence of this predisposing factors, third, fungal spores are quite resistant, which we already talked about, so you have provided an inadequate duration of treatment, and fifth, you have not checked underlying systemic causes like diabetes or any kind of immunocompromised conditions. Okay, so you need to check that and treat that first before you expect a good resolution of this otomycosis. Now thank you for watching this video, and please do follow for more content. Thank you.